there's a tendency to think about biosimilars as biologic generics, and everybody's excited about saving money because price pressures that will exist when we've got multiple substitutable products, just like we've seen with the generic drugs. But these are not identical products, and that same logic doesn't apply. I think pharmacists initially had some frustration in being asked to do some things when interchangeable biosimilars were substituted at the pharmacy level.
Cost piece tends to jump out right away at pharmacists because often that's the part that the patient is most concerned about right there in the pharmacy, because they're paying for that medication there, so they get the dollar signs and they know what is expected of them. So oftentimes pharmacists are playing that role maybe more than they'd like to be, and so they're usually working with patients around if a medication needs to be switched for cost consideration, so if a copay is too expensive, or if the pharmacy benefit manager won't cover a certain product, so we have to switch to a different one for cost-based reasons, then it's up to the pharmacist to explain that while still trying to make sure that the patient understands that the medication that they may be getting switched to is still safe and effective. So the role of the pharmacist then is to evaluate and assess the patient need. Is the other medication, or is this medication that the patient is going to get safe and effective, and it meets the cost needs of the patient as well? It's always good when you can be talking with the patient related to all of those pieces and not just one. So you've got the right medication that is both safe and effective for that patient, as well as you've got something that the patient can afford, and that we're not only making changes based on cost alone.
When interchangeable biosimilars were substituted at the pharmacy level, this category is one that the FDA can bestow upon a biosimilar, and there's no requirement for a pharmacist to contact a prescriber before dispensing that medicine to the patient. However, because they're different, their state laws have been passed, and there are 45 states have passed laws that specify this, that there does need to be communication between the pharmacist and the prescriber and the patient when that kind of a substitution of an interchangeable biosimilar is made.
This biosimilar has the same chemical makeup as the intention, and that it should work the same for the patient. But it may look different. The device that it's in may look different. It's going to have a different name on it, and you want to make sure that the patient is comfortable and confident at home with that medication and knows what to do if anything were to happen with that changeover, and if there's any confusion that comes up, or if there happens to be any sort of change in how they react to that medication when they get home.
So that communication requirement is something that's increasingly being understood as being important, to include the pharmacist in the decision-making process rather than just having them being viewed as the deliverer of bad news. So I think pharmacists are beginning to recognize they have an important role in pharmacovigilance in helping balance effectiveness, safety, and cost considerations so that everyone benefits from the therapy and access to biologics is improved with increased uptake of biosimilars without jeopardizing safety and effectiveness.